Hi everyone and welcome to today's Scottish Drugs Forum webinar. I'm Kirsten Horsburgh, Director of Operations at SDF, and I'll be chairing today's session, which will run until no later than 2:20. This is the fifth of a series of webinars focusing on the medication-assisted treatment standards from 1 to 10, and the aim of the webinars is threefold. One, to continue to raise awareness of the standards. Two, to highlight emerging good practice. And thirdly, to highlight challenges that remain with full implementation and how these may be addressed. Today we'll be focusing on MAT Standard 5. All people will receive support to remain in treatment for as long as requested, and a link to the full standards is provided in the chat. We have three presentations today from Trina Ritchie, who's Lead Clinician and Senior Medical Officer with Glasgow Alcohol and Drug Recovery Services, Kate Ainslie, Manager for Borders Addiction Service in NHS Borders, Angela Swift, Clinical Services Manager, NHS Fife, and Dave Dempster, Substance Misuse Manager, FASS Adapt in Fife. Presentations will be followed by a Q&A session and panel discussion. You can submit questions throughout the webinar through the Q&A tab on your toolbar, and my colleague Jason Wallace will keep an eye on the questions as they come in and he'll join us for the Q&A. So let's get started, and I welcome Trina Ritchie. Thanks, Trina.
Thanks very much, Kirsten, and thanks for inviting me along to talk to this webinar today about MAT Standard 5 and about project development in Glasgow City. My disclosures. So MAT Standard 5, which is about retention in treatment, for me is the big one, the challenge. I think that people put a lot of energy and focus on MAT Standard 1, getting people into treatment, and MAT Standard 2, choice, absolutely. But MAT Standard 5 incorporates value and quality of treatment, and it specifically comments on stigma, dose reduction, and punitive actions as discouraging people away from treatment. So I think all of the MAT standards, obviously, but MAT Standard 1, 2, along with MAT Standard 5, should really encourage person-centered treatment and encourage the people who are not currently accessing OST treatment into quality treatment. And I think sometimes when we're caught up with processes and figures around this, it's easy to forget what that actually means. And it was starkly illustrated for me this week when we were looking at drug-related deaths in Glasgow City over the last 3 years. And it was part of the MAT governance group. So we were looking at people who particularly had OST involved in their, or opiate use involved in their drug-related death. And what it showed is that in the 3 years, 2019 to 2021 in Glasgow City, there were 11 people under the age of 25 who died of drug-related death, which involved opiates. 2 of those people were in treatment for OST, and we know that although OST is evidence-based to be protective, it's not entirely protective, so we can understand those 2 deaths. But 9 people under the age of 25 who were not in OST treatment died of drug-related death with opiates involved. And, and that is what we would expect, 4 times more likely to die if you're not in treatment, but really seeing those cases and seeing those numbers in those young people really was a reminder of how important this is, how important it is to get quality treatment correct. So today I'm going to talk about development in GGC. But Greater Glasgow and Clyde is comprised of 6 HSCP ADP areas. It's often easier to talk about one area. So talking about the Glasgow services. So these figures are for Glasgow specialist care and treatment teams in the city, which are in 3 sectors. And we have a bit over 4,000 people in treatment, 600 people receiving long-acting injectable buprenorphine, which leaves nearly 3,500 people attending community pharmacy for their opiate substitute treatment. And that's delivered from 124 community pharmacies in the city who have dispensed OST as a service. So you can see just the size, scale of treatment services in Glasgow. And one of the things that we are aware of was trying to minimize interruptions in OST treatment. In particular, that can happen if people miss more than 2 days at the pharmacy, and there is a concern around opiate tolerance and whether their dose of OST should be changed. And in order for that dialogue to happen, there has to be quick and timely communication between the community pharmacy and the treatment team. And we were concerned with the pandemic, with pressures on staffing and telephone lines, that this wasn't happening. So as a service development, we looked to the IT system which is used in community pharmacy. So Neo 360 is a system which is used for a variety of things, and one of those things being payments for community pharmacy for OST services. The pharmacy completes for each individual, and what was able to happen was that a further module was developed to give detail around a number of things for the community pharmacy to be able to communicate in to the treatment teams electronically, taking away the need for a phone call.
So it seemed an ideal thing to develop. And what was developed was this here, where you see message types. So there was the ability for each person who's attending the community pharmacy, there was the ability for pharmacy staff to complete either some concerns around 3 missed doses of OST, reporting a concern in general around some aspect of the person's treatment, or if there's a specific prescription issue. So for example, the figures on the prescription don't add up, we need a replacement prescription, and things such as this. So just to tell you a little bit about how this was developed. First of all, as people will be familiar, a paper or a situation background assessment and recommendation SBAR was written proposing that these changes could be made to the module, asking for a small amount of funding and describing how the changes would be implemented and reported on. The actual changes needed to be made to the electronic system itself. The user guide for the people in community pharmacy who were using the system and entering the information had to be updated. The guidance for the specialist teams around missed doses and that the team would start receiving emails back had to be updated. A standard operating process for when emails were received into the teams. I realize that I've missed a step in explaining. So if I go back to this screen, sorry. Once the community pharmacy have filled out these boxes, you'll see up above it says ADRS team, which is identified from the cipher number on the prescription, and the system is set up to automatically send these messages that are entered in the pharmacy into standardized email inboxes in the community teams. So this example on the test system here is for somebody who's receiving treatment in Easterhouse in the northeast part of the city, and that message there saying that the last supervised dose was the 3rd of October, has missed 3 days, which automatically gets sent into the team's inbox. That's a bit of an important miss. So a standard operating process was required for the teams to know what to do when they were receiving these emails, which ones needed passed to the care managers and the duty teams, or if some were just for information for noting in the records. There needed to be information sent to community pharmacy for to make sure that everybody was aware of the launch of the change. And information needed to be sent to the specialist teams to tell them about the changes that were coming and the emails that would be received into the teams. Then once it had started, the module activity and that was coming into the teams, and then the responses from the teams to the information needed to be audited monthly. And those reports then obviously needed to be taken to management and governance meetings throughout the city so that people could see where there was activity, where there were responses, and what any service learning was. And I think one of the reasons why I have detailed all of this out is also for us to think about all the implementation of the MAT standards, and for every little development, just really wanted to illustrate how much work one change and one development can lead to. So you see, in just under a year in this period, there were over 900 episodes of OST 3 missed doses were captured, and 98 of the 124 pharmacies, so 80% of pharmacies had used the system and had sent electronic messages that way. So we think that really was pretty successful. We have hugely reduced the amount of telephone dependence on telephone communication from the community pharmacies into the teams, which was described, reported throughout the pandemic as a particular issue and pressure. And we have seen a lot of activity in the system. I think in terms of our next steps and continued challenges, so we have this set up in the specialist treatment teams. Our shared care colleagues can't take advantage of this at the moment because of the timescales around what the expectations of response to their email practice inboxes is longer than what would need to be in place for missed doses. And we're currently really working on our monthly audits around consistency of response in the teams and ensuring best practice. And our next steps really are that is really sort of further implementation of MAT Standard 5. So looking at things like disengagement plans and anticipatory care planning, so that we make sure that we have that in place before we're being notified about missed doses in pharmacy and similar. Thanks, Kirsten.
Thank you, Trina. That was great. Thanks. And I'm sure we'll have some questions for you at the end. Thanks a lot for that. Okay, I'm just going to move us on to Kate Ainslie, please, from NHS Borders Addiction Service. Thanks, Kate.
Hello, and thanks, Kirsten. My name is Kate Ainslie. I am the Borders Addiction Service Manager. Thank you, SDF, for the opportunity to come back and talk today and talk about MAT Standard 5 and talk about all the things that we're doing in the Borders to implement and continue with the kind of changes in practice that we've implemented. So as you can see from the first slide, the Scottish Borders covers a large geographical area, which we have a relatively small population, especially if you compare that to Glasgow and what Trina's just delivered. The pockets of small towns and villages spread over kind of a substantial area, and the geography of the Scottish Borders really creates challenges in being able to provide care and treatment equitably. So there's no primary care prescribing of OST in the Borders, so it all remains with our service, and that obviously increases the reliance upon our service to produce and provide effective and an efficient care and treatment throughout as well. You can see that our total caseload, again, in comparison to Glasgow, we've 467 in comparison to their 4,000. So next slides, please. So we know that MAT Standard 5 is concerned with how individuals are supported to remain in treatment for as long as necessary, and really focus on those key transition points that create risk to safety, but also to disengagement as well. And it's about reducing the unplanned discharges, moving away from those punitive practices, those 2 strikes and you're out kind of practices that we've all heard of and are trying tirelessly to move away from. It's about more realistically meeting the needs of individuals and adding value to care and treatment and creating flexible services that meet individual needs. We know that being in treatment safeguards, but it's also about having conversations like Trina touched on about how people come out of treatment when they want to, and doing that safely and with the correct support as well. I'm hoping just to touch on some of the historic and the current challenges that we experience in the Borders, and also talk about some of the changes in practice that we've implemented. So touch on the engagement support team that we've got now, and then an non-fatal overdose pathway, and also some of the ways that we now flexibly deliver services to meet needs. And also consider the other standards that, again, I agree with Trina that this standard is the crux. This is what we want to achieve, to be able to have services that meet need realistically and add value. But I think obviously there's a lot of overlap with this standard, and you need to make sure that you've got other standards right so that people do want to remain in services for longer. So next slide, please. So you saw on the first slide that the size of the Scottish borders, and this obviously introduces challenges when it comes to transport and moving around. Just put it in context, traveling somewhere from like Eyemouth, which is a hard to reach town on the edge of the borders, to our base in Galashiels can take up to 2 hours. And I've heard stories about people in years gone by, which Kirsten might remember, having worked in the borders herself as well, people being asked to travel from places like Eyemouth to our base in withdrawal to attend tolerance testing clinics. I heard one gentleman's story about how he was fecally incontinent on his travels to Galashiels, and how actually he turned around and went home, but was discharged from the service because he was seen to be unmotivated to start treatment. So again, these poor transport links create barriers and introduce postcode lotteries to how people access support. People in more populated towns like Galashiels and Hawick have obviously got more access to services on hand than those in kind of more remote towns. And again, like most small communities, there's an increased incidence of stigma and discrimination, and people that we work with, you know, report to feel a lot of shame. And we've done a lot of work since around the 2019 mark to try and challenge some of that as well. Historically, and prior to changes in practice, all of our appointments were in GP practices or health centres. And again, this introduced stigma and discrimination and huge DNA rates. Prior to changes in practice, we were sitting at around DNA rate of about 50%, which, you know, looking at our services as a whole and the resources, just had huge issues with efficiency and how we were supporting people as well. I've touched on punitive practices, but again, when I started working with the team, there was cases where if people presented and they were using substances or they missed a couple of appointments, prescriptions were halved and stopped, and people still hold on to those negative perceptions of services. We are working with an ageing population in the Scottish borders, so a lot of people have got a story of practices that really influence how they now engage with the service, and there's been a lot of work to try and rectify some of those relationships and improve things. Again, historic large lengthy wait times to get onto a treatment impact on people's trust and belief in the service as well. Historically, people would wait up to 6 weeks to get onto a prescription, and there'd be requirements and hoops people have had to jump on to really evidence the need for a prescription as well. And again, I guess, you know, people often reflect on the practices and wonder why things were the way they were. And I think, you know, pressures on services from heat targets did encourage these measures, I think, as a means to try and improve efficiency and safety. But we know that that's not the case. We know that even with these measures, there was a high incidence of drug-related deaths. And I think the time's now come that we need to focus on how individuals' needs can be met, as opposed to how individuals can meet the needs of the services. Next slide, please. So in 2019, and in response to a huge rise in drug-related deaths nationally, but also locally as well, and drug-related harm, the engagement support team was launched within the Scottish borders, assertively meeting the needs of those that are most hard to reach and vulnerable within the community. This team of this part of the service is headed up by a nurse, and it's also has We Are With You recovery workers as well. Again, support's tailored and focused on the most vulnerable and the most hard to reach. It's about removing barriers and in supporting people to access services, having rapid access to prescribing, and working to promote better engagement, more realistic engagement that suits need and suits lifestyles as well. Introducing more realistic harm reduction, actually listening to what people want, and diminishing those punitive practices that we'd saw, you know, previously as well. The team has a low caseload, and it's aimed to work quite fluidly so that it can respond to those most vulnerable and those most at risk in a very responsive and timely manner. And I've also got the time to work with people in a way that they want to work with the service as well. We work quite innovatively and creatively to engage people, home visits, telephone calls. I've known people to be tracked down using Facebook, Simple things like mobile phones that we all take for granted. If someone hasn't got a mobile phone, they're not able to access support that they need. So we've been in a position where we've been able to provide mobile phones to individuals as well. We've also looked at how we can improve access, so acknowledging those poor transport links. We've now got bus tokens that we can offer people and a taxi account. And we've also, it's been known for members of the Esteem team just to go and pick people up, to bring to people to not only their addictions appointments, but mental health appointments, physical health appointments as well. They've recently, or I'm saying recently in the last couple of years, set up a football group as well of people that didn't necessarily want to talk about drugs, but they wanted to engage with support in other ways. And that's been really positive as well. It's about anticipatory care as well. Again, something that Trina touched on. So we know that there's critical points in people's journey, life events or triggering times that we know increases risk of disengagement and also risk of harm. And it's about applying resource at those times for individuals so that they do feel that they're being supported and listened to. So next slide, please. Again, acknowledging that non-fatal overdoses is a precursor to drug-related deaths. We were very aware in the Scottish Borders that we were missing a process by which we could identify and respond to those most at risk in the community. So in 2021, and after lengthy discussions around information sharing, a pathway was developed that linked Borders Addiction Service, We Are With You, the Scottish Ambulance Service and the police. And it was really aimed at improving communication and response to risk. The Esteem team were integral to the development of this pathway and oversee the response to individuals as well. Currently, a multi-agency group meets twice weekly and they discuss all non-fatal overdoses unless somebody has opted out. The aim is that we are responding within 48 hours of that non-fatal overdose. And again, some very innovative and creative ways that the team have worked to make contact with those individuals. And support could be about re-engaging with the service, looking at how the service can adapt to meet individual needs, re-engaging with a key worker, but it can also be about bringing people into treatment and finding the most correct treatment for that individual as well. And there's been some really positive anecdotal accounts of how people have felt that actually having the team respond to them has improved motivation and allowed them to feel important and that it matters as well, which I think previously non-fatal overdoses were being missed and people didn't feel like they mattered. So next slide, please. So in 2019, at the same time as the development of Esteem team and the discussions around NFO, we were actively looking and exploring how and where the support was being offered to people in the Scottish Borders. And this led to the development of a drop-in model, which again, more realistically met the need of the community. Again, these drop-in services brought together NHS, third sector and council staff, all under one roof and really focused on multidisciplinary team working to ensure that people had rapid but more holistic access to care and support all in one place. The drop-ins don't require appointments, so people can choose how and when they attend. It simplifies pathways, it promotes flexibility and it promotes inclusion. So people have got access to being able to shape and participate in their care and treatment. The drop-in services and Esteem have promoted increased access to same-day prescribe and actually moving away from those clinical environments where people only had half an hour to discuss drug use, provide a sample and discuss anything else that was going on with their life. These drop-in services offer greater capacity to have more realistic care, treatment and support, and offers opportunities for more open discussion about what's going on in someone's life as well, which ultimately leads to better discussions around risk and better opportunities for harm reduction as well. We've seen a huge improvement in our therapeutic relationships. I think just sitting down and having a cup of tea with someone and really removing some of those barriers to care and treatment has improved people's beliefs about the service, and people want to work with the service as well. Next slide, please. So the drop-in model is now integral to the way that we deliver support in the Scottish Borders. There's five drop-ins located around kind of hard to reach areas in the Scottish Borders. And our engagement support team is embedded within those drop-ins. It makes very good links with those drop-ins to really support engagement and bring people in to receive support. There's no pressure at times to talk about drug use. People can come and access different activities or advice, but they don't necessarily need to come along and talk about drugs. It's just about having contact with the service and, again, developing and building on those trusting relationships. It's about having a holistic approach that enables people to have choice about how they engage and who they access support through. There's a bigger emphasis on social prescribing. So not only things like housing and finances, but people are able to access haircuts and complementary therapies, food. We have lunch every week when we meet in the drop-ins. And again, I think the focus is about bringing down those barriers and making support real and in line with lifestyle. The drop-ins tend to be in community buildings, again, in centre of town. So they're really there to challenge that stigma and discrimination and promote that inclusion as well. And some of the anecdotal accounts that we've had of people accessing the drop-ins and some of the relationships, the improvements in relationships between staff and people accessing care and treatment, it's been remarkable. Next slide, please. So I mentioned at the start, there is great overlap between all of the MAT standards, and I think none more than with MAT standard 5. And I think if you're considering retention, you'd be naive not to acknowledge other aspects of an individual's life and how this may impact on motivation and capacity to engage and remain with a service. So here at Borders Addiction Service, we're currently running a test of change to see how we can support access to primary care. I mentioned at the start that we don't have any opiate substitute therapy being delivered in primary care services. So that has made kind of the implementation of MAT standard number 7 very difficult for us. But we know that people that we work with have huge health inequalities. They don't attend for routine health monitoring, and management of things like chronic diseases can be really challenging. So we've introduced an advanced nurse practitioner to really work with individuals to ensure that at the point of MAT delivery, they have access to physical health checks. They are able to look at things like medicines that they're on, wound care, any infections they may have, maybe able to get started antibiotics, things like contraception. And we're running these as health roadshows that are based on our drop-ins as well. It's not about removing primary care services or removing anything from primary care services, but it's about bridging those gaps and, again, creating that holistic approach. It's about assertive and proactive medicine. Next slide, please. And likewise, when you consider the implementation of MAT 9 and acknowledging the high incidence of contact with mental health services prior to a drug-related death, we've implemented an advanced nurse practitioner to act as a care coordinator, kind of liaison role within the community. Again, focusing on mental health needs at the point of MAT delivery to provide that holistic care. And it's, again, about navigating and simplifying those complex pathways. If you have an individual who is engaging in substance use and maybe is self-medicating because of mental health issues, they don't quite meet the threshold for community mental health services, but are often deemed too complex for third sector services. This advanced nurse practitioner role is seen there to kind of bridge those services and promote a kind of holistic response. Next slide, please. I mentioned, obviously, the overlap with other standards. And I think, again, ensuring that you have access to same-day prescribing, better choice, more realistic harm reduction, trauma-informed practice, and social support, ensuring that you have access to this is going to make services more desirable. It's going to make people want to engage with services if they're getting that holistic, all-encompassing support that really matters. It's not just about focusing on the drug use and about how we can keep people in. It's making sure that the services that we have, that we're offering people, are realistic and meeting those needs. Next slide, please. To date, Borders Addiction Service is reaching around 75% of the drug using population. I spoke about some of the practices, obviously the changes in practice since around the 2019 mark, and that saw a huge increase in our caseload. So usually we would sit around kind of 300 mark, but since the changes that I've outlined, we're kind of sitting around the 460 mark for our total caseload, which is an increase of just over 50%, which, you know, obviously has impact on caseload, etc. So the average wait for prescription is now around 6 days. 44% of people accessing treatment receive a prescription on the same day. And I know the focus does seem to be all around MAT standard 1, But I think to be able to retain people in treatment, it's really important that you're able to offer a responsive service to make it more realistic to individual needs. Our DNA rate has dropped from around 50%, which I mentioned at the start, to 60%. And people report to have much better belief and understanding of the service, which for us is what really matters. These achievements don't obviously come without challenges. And I mentioned there's obviously increase in caseload. That comes with a great demand upon resources, potential there, I suppose, for staff burnout as well. There's an expectation now that we're going to be a very responsive service, that we're going to be able to respond to need quickly. And that's obviously led us to consider other new emerging drug trends and how we hope to respond to those. But again, these things need resource. Sometimes it can feel like we're a victim of our own success in some ways as well. Again, I can see that Kirsten's come back on the screen, so that's really my cue to wrap it up. But if anybody does want to talk, my next slide, I've got my details on, and anybody can feel free to contact. And we've got a Q&A session at the end, but if anyone does want to get in contact, feel free. Thank you, Kirsten.
Brilliant. Thanks very much, Kate. And also thanks for the reminder of previous work in the borders, and quite unbelievable that we thought some of those, or that those practices back in the day were thought to be okay for people. I remember joining the service as a new nurse and that being the way, and whilst that was maybe 12, 13, 14 years ago, still unbelievable that people were made to go through that type of care. So it's taken a while, I think, for people to forget about some of those old practices and to have confidence in new practices that are coming forward as well. So thank you, and we'll come back to some of that for sure at the end. So now just going to invite on Angela and Dave from Fife, please. Angela and Dave, over to yourselves. Thank you.
Good afternoon, everyone. My name is Dave Dempster. I'm the Substance Misuse Manager with FASS here in Fife. I'm here today with my colleague Angela Swift, who's the Clinical Manager NHS Addictions Fife. So we've been asked to talk today somewhere about MAC Standard 5. What happened in Fife in the run-up to implementation of a retention service for MAC Standard 5 and was that in 2021, our Clinical Manager of Addictions, Angela, highlights and identifies the needs for patients falling out of service and looks at how we retain people in that service, which falls into MAC Category 5. We made an approach to our local ADP through our ADP manager, Elizabeth Butters, who was good enough to speak to Fife Health and Social Care Partnership, and we were awarded a small sum of money to present a retention service. So in November 2021, the new Fife Retention Service began. Its primary aim to help identify with partner agencies those most at risk who have fallen out of treatment services, to look to seek, engage, support and aid their return into services that they had previously engaged with. The service is a frontline assertive outreach service to engage with those most in need. This included working with service users to provide enabled focus interventions through ongoing support, practical assistance and problem-solving resolutions in support of Fife ADP and Fife NHS and clients. Our aim is to participate with a multidisciplinary professional team in the relevant pathways and protocols in Fife to deliver safe person-centred working approach, assessments, care plans, building relationships with clients, which is key for what we do. The aim is to work in partnership with all relevant services for clients, both statutory services and third sector services. But most importantly is to work with families and significant others to ensure the service outcomes are met and their needs are met for their loved ones. The aim of the responsibilities of this new retention service was support service users with their journey, assist with social needs, provide a wraparound service to those most in need to help prevent unplanned discharge within this vulnerable group. It's also to find out awareness of why patients have fallen out of the system, to help those service users access and gain resources, including things such as benefits, welfare rights, GP referrals, and food and fuel poverty, which is very high in demand for our clients. The aim to help identify early signs of relapse by monitoring the service user's progress, level of functioning, their social and mental health, and to provide simple interventions as required and work closely with clinical colleagues to problem solve patients' issues. What we did was we set up a whole referral process system and service user contact. Our workers attend clinical meetings, which allows for sharing of information relevant to clients in a broader spectrum, such as building relationships with nurses. This affords a direct link with the service our service in NHS, allowing for referrals to be made, smooths the way for two-way communication, allows for rapid access into treatment and to remain in treatment. So all referrals are received from NHS addiction services via retention referral form. This provides a service user overview, risk assessment, allowing us to record all relevant information. The retention team aim to make contact with the service user within a 3 to 4 day timescale, although usually we achieve this within 48 hours. An appointment letter is sent out for scheduled home visit. At this point, the assessment of need is carried out, a care plan mandate, and contract of service completed. Contact is then made on behalf of the service user with addiction services. If service user wishes to re-engage, an appointment date and time given for clinical treatment. The retention team support clients to all initial appointments. Some stats to date. Since the beginning of a retention service in November 2021, we've had 171 referrals which have been received from clinical services. Our initial target was 50 to 75. 54% of these patients have successfully re-engaged back into clinical treatments, and 46% have supported or referred to other support services. We also offer additional support in many other areas. As I said earlier, food and fuel poverty are really high in demand. Travel vouchers, mobile phones, housing benefits, clothing, GP and dentist registrations, and additional medical referrals. Naloxone kits are offered to every service user and family member, and signposting to other support organisations for everyone. So from these 171 referrals to date, we've had 17 clients have re-referred who had fallen out of the system more than once. 9 male clients re-referred twice, 1 female referred twice, 3 female clients re-referred 3 times, and 2 females re-referred 4 times. I put this slide up because it shows a demographic of what we've learned from this. A lot of clients who fall into drug-related death within our area have obviously fallen into this category. This has allowed us then to have a more focused approach in implementing a rapid access to treatment within the area for us is methyl KY8. And their services, along with addiction service nurses, are now doing a rapid access to treatment and prescribing services. But for us, what I highlighted is that, as it says here, 18 to 19, 2 unique male clients who had fallen out of service, 20 to 22, 2 female and 5 male. But the most interesting part was 25 to 40, which shows 37 females and 51 males have fallen out of service. 41 to 50-year-olds, 14 females and 35 males. 51 to 54, 1 female, 10 males. 55 to 64, 2 females, 10 males, and 65 and over, 2 males. Grand summary of 56 females and 115 males. Next slide, please. Some of the challenges we experienced, similar to some of the previous speakers, but for us, some of the difficulties in locating service users due to their chaotic lifestyle. Perhaps they no contact number, or they lost their phone or got rid of their phone for whatever reason. Try to make contact at permanent addresses. A lot of clients had went on to be sofa surfing, moving around, no stable address. So like other services, we have to get out there and we have to make contacts with our fellow agencies in Fife, where we make contact and they highlight and let us know where the person may possibly be. Mental health is predominant in most cases, and waiting times can be significantly lengthy for mental health assessment. Supporting service users to remain recovery focused. In some cases, longer-term support is required. Awareness of statutory and third sector support and funding streams available to the client group has been very beneficial, which has allowed us to help and assist people into treatment to deal with some of their personal issues. Next slide, please. I thought I'd put up some feedback from service user. The retention team have saved my life, blown away by kindness and support. My workers are angels. With your help, this is the longest time that I haven't been in jail. You understand me. I can speak to you. I'm not judged. My treatment is better now with retention and addiction nurses. I think what's important here is one of our models is building relationships to save lives. And I think this comes through by the fact that we get to know the people and we go the extra mile. This has made a big difference for when we engage with people and try to get them back into services. Next slide, please. I thought I'd finish off with some testimonials of people who have been in service, fallen out. We've successfully engaged with them, got some treatment and they're still in treatment. This service was so useful for me because I needed to feel like I was someone. Alcohol takes away everything. I use help me. It's just the right bit at the right time. I'm grateful for you guys. It's weird being sober, a totally different world, and you helped. John, 56 years old. I write this note to thank Adapt, particularly 2 girls that I met who worked for them. I was given a court order to get my drug taking in order. I was the lowest I'd ever been in my life. I had contemplated taking my life. I was given a chance of help, but I had no way of getting to the hospital and leaving. These 2 girls, who I did not even know, came to Cooper and picked me up and took me to my appointment. I didn't have the strength to do it myself. If it wasn't for those 2 girls, I honestly don't think that I would be here. Personally, I think they do a wonderful job. I write these words just to say thank you for what you said, for what you did. Thank you, girls. Mark, 53 years old. Next slide, please. Leanne, who's one of the workers. Something happened to me today, and I was thinking, this is the longest I have stayed out of prison for 18 years, and I think it's because of you and Gail. You have both helped me so much and gave me hope when I have been at my lowest. Never gave up on me, even when I have been rude or angry to you. You have still been there for me and gave me hope and fought for me to keep on going and never give up, even when I have been on the curb and in the gutter. I really don't know how you managed to go home and then go back to work next day. No one has ever managed to make me see potential like you have in my life. I see things differently, and it's all because of you. I just want to say thank you for all the support you have given me and never gave up on me like everyone else. Make me feel like I am worth fighting for and give me hope and make me feel strong. And I just want to say thank you for not giving up on me, even though I am an ass sometimes. You are just not important. You are not just important workers. You are my friends. Thank you for not giving up on me. Graham, 43 years old. Hi, I want to say how helpful and uplifting the work that you and Gail do is. You have a much stabilising factor in my life, especially when I seem to be falling. You have been there to pick up the pieces and put Humpty Dumpty back, and I so value even a call with one of you. You can shift me out of the shadows and back to light. I'm not sure I'll ever be able to truly thank you for the commitment you have given to myself, and I'm certain that there's plenty of others that feel just as blessed. Thanks anyway, with my regards, Carol, 33 years old. I think the important part here is building the relationships, the transition from engaging with people and working alongside our clinical partners and getting people back into treatment. I think what we see here is the benefits. There are many challenges that we still to go through, but I do believe that we are on the right path. Thanks for listening. Look forward to any questions later.
Thanks very much for that, Dave. I'll just invite everybody then back to join us. If you could all put your cameras back on, please. And also my colleague Jason Wallace is going to join us now. Jason's been keeping an eye on the questions in the background. Thanks very much for everybody's points that were raised throughout the presentations. I just wanted to ask Jason first, in terms of the work that you've been doing with the living experience engagement groups and the work that you've been doing more broadly with people who are accessing services and who may be in and out of treatment sometimes, what's your sort of thoughts and feedback from people around this standard around being able to stay in treatment for as long as people request? Thank you.
Yeah, thanks, Kirsten. So I suppose the groups we work with have been broadly supportive of the MAT standards as a whole, and they appreciate having them. They feel it gives them a wee bit more knowledge and something that they can take along to the service with them and stuff, to try and improve the type of service they're getting. But with this standard in particular, one of the worries you always hear for the people that attend the groups is if they come through that pathway, I think it was yourself described, Trina, and they decide to disengage, what is the options for them to go back into treatment if it doesn't work for them? Within can they get back in relatively quick within the first couple of weeks or so? Because a lot of them worry that they're not sure how it will turn out, and that is a barrier for taking that step out of treatment. So I'm just wondering your thoughts on that.
We have open access services. So, I mean, first of all, I think when somebody's choosing to stop treatment, ideally they shouldn't be closed to treatment services, obviously, because it's a high risk period. But if somebody has chosen to leave treatment services totally and they've been discharged, then they should be able to come back the next day. And we have self-referrals or referrals from a whole variety of places. So there's no time scale that somebody has to pass through to come back to treatment. It's been one of the really good things that we've seen with Buvidal, where people have detoxed, and if they have relapsed and needed to come back to treatment, people have come back really quickly. And some of that obviously is around, thinking they can come straight back onto Buvidal. They wouldn't have that period of titration where they have to go for supervision daily at community pharmacy and things like that. So yeah, we are seeing people come back into treatment very quickly if they have to.
Yeah, thanks. The other part of that was just whether the panel thought our staff explaining that to individuals, or is that part of the discussion that they're having with people, because it doesn't feel like people are getting told what you just described there, Trina. And I'm not just talking on behalf of the Glasgow group, I'm talking about all the groups that are in existence.
Thanks, Jason. I'll maybe just come to Kate first on that one, because Kate, you had a point to make on the last one. And your mic needs turned on.
Sorry, it had to be someone that did that today. Yeah, just agreeing with what Trina said, and obviously just picking up with what Jason said as well. I think there is a bit of fear that if people disengage or people come out of treatment, about how they get back in. More recently within the borders, we've had people that are not on a prescription any longer with us, but are still able to access the services at the drop-in service. So those services are to anybody who is or has been affected by substance use. And that has kind of bridged that gap as well. It's allowed people to have kind of informal chats with staff about, I'm really struggling, what are the options for me going forward to get some more support. But again, it's about putting that kind of control back into individuals' hands, so that they can kind of choose how and when they do that, and dip in and out how they feel they need at that time as well. Hope that answers your questions.
Thanks, Kate. And I think in terms of this whole discussion, I remember when the MAT standards were being created, and the specific wording that went into this standard in particular, because the word requested, so people being able to stay in treatment for as long as requested. There was a lot of discussion in terms of should it be as long as needed, as long as required, but then it almost felt like that was then placing the decision on perhaps the clinicians. So the requested part was important, because it's about links to what you were saying, Jason, as well, as people being in treatment for as long as they want, and not being time limited, but also as short as they want as well, and being able to have those processes where people can access back into treatment if they choose to do so. But massively important that we make sure that people know about the standards, because we talked about some of the poor practice, Kate, there from back in the day, and that exists in a lot of areas, and also still exists in some areas, but also it's important that when there have been changes in a service, that those are able to be communicated really well to the people that are using the service. I don't know, Angela, did you want to add anything on that so far? And then we'll go to Jason for the questions that have come in from the chat. Thanks.
Just wanted to say that yes, in Fife we historically have had longer waits for treatment, but now where there are individuals who want to remain within the service, they can do that, but they can also re-engage, and they can re-engage through Dave's team, and we have rapid access clinics Fife-wide that run, as well as drop-ins that Dave's team runs, that addiction services staff are part of.
Thanks, Angela. Jason?
Okay, thanks. So this question's directed for yourself, Trina, and they're just asking for the pharmacies who never used the online prescribing module. Did you get feedback from them, and did they tell you why they didn't go for that? And they're asking it because they think it will be useful if you were to roll it out more widely.
Sure, thanks, Jason. Yeah, so I think partly it's a case of, some people are quicker to adopt new things, and that we're continuing to see more pharmacies use it month on month. So I think part of it is just there's early adopters and then there's later adopters, but also as you know, as the services are having problems with staffing retention and turnover of staff, it's the same in community pharmacies. So part of it will be around just not having the ability to get staff aware that it's there. I think certainly our central pharmacy team are supporting the pharmacies and visiting and making sure that there's awareness of it. So we would hope that we would see all of the pharmacies adopting its use. The feedback's been really positive for the pharmacies who have been using it. I should have said that, sorry. You know, like really saying that it cuts down on time in terms of communicating. So given that it's been so incredibly positive from the pharmacy point of view, I hope that I would be back another time saying that 100% of pharmacies have adopted it.
Thanks, Trina. This is a question for yourself, Kate. Just in terms of the drop-in you described, the individual is asking, does this need to be an advanced nurse practitioner who does this, or could it be a support worker? Is they're just saying that they deliver health checks, naloxone, etc., and they find the idea of drop-in really good?
It's a test of change at the moment. If we're talking about the primary care side element of the drop-ins, the Healthy Road shows there is an advanced nurse practitioner that is kind of leading on that because of the nature of the test of change. However, the plan is that we do recruit a support worker to add to that and to be able to do some of that kind of health monitoring as well. So at present, it is just an advanced nurse practitioner, but there is no reason why a support worker couldn't do it. I guess at this point in time, it's just come down to the resource we've got, and we've only been able to recruit one person, and that's been an advanced nurse practitioner.
Okay, thanks. And this question is for the whole panel. So during the presentations there, it's been mentioned a few times about staff burnout and capacity. How are organisations actually looking after staff's well-being, and what benefits, support or working conditions would help improve the working environment for staff?
Okay, who wants to take that first? Any offers?
I don't mind going first. So
okay,
obviously,
come to you, Kate, and then go to Dave. Thanks.
Yeah, we've seen a huge number in the caseloads of the Borders Addiction Service, and like I say, I think it was around 55% increase, and that coincided with the time of COVID as well. So we were already kind of riding that emotional roller coaster of kind of restrictions, and everybody else had lots of things going on around that time as well. I think increased supervision. We can only kind of do what we do with the resources that we've got as well. We can aspire to be as responsive as possible, but it has to be sustainable, and it has to be enough for to ensure that staff are protected as well. We found that specifically with the non-medical prescribers, having increased supervision on a regular basis so that we don't feel isolated in some of our practices. We've actually, at the time when the caseloads did start to really peak, we went to the ADP to ask for more resource, and we were in a position where we could actually recruit more staff, which took the pressure off staff in terms of those big caseloads. But the drop-ins have been a really good way of being able to see a high number of people in a time frame and provide therapeutic, valuable work, which, although caseloads have risen, we probably haven't felt them as much because of the use of the drop-ins and the way that we are now practicing. So it's not so reliant on individuals to see individuals in like health centres and to cram appointments into those clinics. It's a team approach, and it's a multidisciplinary team approach. So that in turn takes a bit of the pressure off. But I would definitely say during that period when the change was being made, there was a lot more need for supervision and reassurance about the kind of direction that we were going in. So yeah, I hope that answers it.
Dave, do you want to add to that?
Yeah. I think we're quite fortunate. We also have a counselling service as part of our service. So we have somewhere in the region of 30 to 40 counsellors. So we've implemented a monthly counselling supervision service for each outreach worker. And if anything is identified from that, then they're asked then for external supervision. Maybe a bit I shouldn't really say. My workers manage their own diaries. I don't micromanage, and I encourage them if they need to nip away for a haircut, go to the dentist, pick their child up from somewhere, I encourage that with them. We've incorporated a Friday fun day every Friday morning where we all get onto Zoom. And I come on for 2 minutes, then I tell them, now you can start moaning about me and I'll leave. So it's about trying to embody them with it. And as Kate was saying, we've got a really successful drop-in Fife. As I said earlier, from our learning, we opened a drop-in that has a focus on near-fatal overdose and drug-related death. And Angela's prescribing nurses attend. I think in the last 4 or 5 weeks from it, we'll prescribe rapid access treatment for about 12 people just from that one drop-in. But we try to make it a bit fun for those people. You know, we don't structure it so that you must do this. It's about people coming in and take ownership. And even the workers who are out in the community who are not part of that go down and participate. So I suppose it's just try to make people enjoy their job as best you can.
Thanks, Dave. I'm just going to take Chair's liberty for a second, if you don't mind, Jason, because the question that's on my mind, and I've noticed that there's something just come in similar lines in the Q&A, is around the Fife situation, Angela, in terms of what do you feel the main things, the main reasons are why people are disengaging from the service? Because ultimately, surely we would want to get to a situation where we sorry, Dave, but we wouldn't need the retention service because we would just be retaining people. So yeah, just any thoughts that you have on that would be helpful. Thank you.
So what we found is that people, when they first started on treatment, can disengage for a variety of reasons. And when we talk about disengage, it might well be somebody missing 3 doses or 2 doses of their prescribed medication. So, and it could be their mental health. And what we are finding is there are more and more people who are really quite, complex. They've got comorbidity issues, for example, and through Dave's team, they can re-engage that person and support us. There's 375,000 people in Fife, and there's a mix of rural and urban areas, and it's really quite difficult. We've got 3 static sites that the clinical staff work from within addiction services, and sometimes with the higher caseloads, it's really quite difficult to be as flexible as we would like to be. So Dave's team, their team has been absolutely fantastic in terms of they're co-located with us at one of the sites. The plan is to hopefully have the accommodation that we could be truly co-located so that they can engage that person, go out to the person's home and actually ask them what is going on so that we can try and then continue their prescribing and treatment, because, as people have said earlier, being in treatment is a protective factor.
Okay, thanks, Angela. Jason, sorry for that.
Thanks. So the next question we have is quite lengthy, so it's kind of 2 questions in one, if you don't mind, and I'm just summarising this. So firstly, they're asking, what does the panel think people still being stigmatised and sometimes refused aftercare, and why do people have to, and I'm just using the words that the person's put in the chat, why do people have to be clean to get into treatment to get off drugs? And I'm imagining the treatment they're referring to is residential treatment.
So I guess maybe there's a sort of more general question there around some of the barriers and stigma that still exists and some of the restrictions that we often have in our services. So maybe just some general thoughts about how we've tried to address some of those barriers in terms of what we ask from people. Because I remember back in the day about significant asks on people in terms of, I know this isn't particularly a retention question or a staying in treatment for as long as possible question, but for instance, in a service that I worked in, having to have people given drug urine tests that were negative for benzodiazepines before they would get started on opiate replacement therapy. So I get, maybe there's something general about how we try and work with the person. Trina, sorry, that's a bit probably unclear from me, but any thoughts that you have on Jason's point and others?
I think it's just as people have talked about already, that the importance is around that person-centered plan, and it's every aspect, isn't it? So from finding out what someone's situation is, things should be set up in a way that someone isn't needing to answer the same question 100 times. So right from that, just gathering the information all the way through to somehow within our resources, managing to offer people a range of options and agreeing a person-centered plan, I think. Ensuring we have issues with vacancies, with staff turnover and things, as we've been discussing, and so ensuring that there's good quality training and that good practice is identified and celebrated, I think is really important as well. Can I jump in on the second part, just on the...
Yeah, absolutely. Just before you do, Trina, and it might, in terms of, I don't know if it will link to what you're going to say, but in terms of access to residential rehab, one of the things that I find particularly stressful about this idea that you have to be abstinent before you get into a lot of the residential rehab settings is that risk period. So once somebody's made a decision that they want to access residential rehab, often they're asked to reduce down greatly on, say, their methadone prescription prior to going into residential rehab, and that risk period for me is really high in terms of drug death prevention. So sorry, just wanted to add that in as well, but please carry on.
Yeah, no, that's helpful. But I think what I was going to say is that at the end of the day with residential rehab, that there is a finite resource. So you can either have less people in for a long stay or more people in for a shorter stay. And so for that example that you gave, Kirsten, if somebody's still on quite a high dose of methadone and they go into residential rehab and they're going to do that detox, they then ideally would stay in residential rehab for long enough to benefit from residential rehab and not be in a high risk period when they were then leaving. So that's quite a considerable length of stay, which I think everybody would like everyone to have a considerable length of stay, but because of resource, you need to balance how many people can then access it. But, and the actual question about being drug-free to be admitted, again, I think is around resource, because within a budget, if a service is saying we can do X amount in the budget that you're saying that you can commission our service for, then one of the things that they potentially can't do, which is expensive, is have a lot of medical input. So if you're using a lot of street drugs and you go into a service where you're going into a room behind a closed door at night with no sort of health staff employed in the service, then how would that safely be managed? How would we make sure that that person didn't have benzodiazepine withdrawal seizures overnight and die in the 3 days after admission sort of setup? So it's about resource. I think you could have a model out where anybody could go in from any level of chaotic street drug use, but how that would be managed would require a lot of medical, nursing, health input, and that would affect the cost of the service.
Thanks, Trina. Did anybody want to add to that? Shall we?
I was going to say, I think the question was about kind of aftercare and being stigmatized about access and aftercare. And certainly, I think as services, we need to get better at planning what happens post-discharge. There's obviously a high risk time, and we can say that people can access drop-ins and they can remain on our kind of books. But actually, we need to be doing more, and we need to be working with other services, not just drug services, I think, to kind of support people to live a life that doesn't have the support there of services like long term. Certainly when it comes to things like primary care, I know that some people that I've worked with might not be working with the treatment currently, stable and absent of all substances, but they're still stigmatized when they go and try and seek things like analgesia. So there's still a lot of work to be done, I think, in other services about how we make them more accessible without discriminating against people because they've had a historic or a current substance use problem. And that's something that we see day in, day out. everybody has the right to pain relief, regardless of what the prescription on. Yet it might take different ways of planning it if there's potential for more risk. But I often hear that people haven't got access to those kind of treatments, which is, it's really sad, really. People are being treated differently.
Thanks, Kate. Angela, you wanted to come in as well?
Yes, I was just going to say Fife doesn't have its own inpatient detoxification or rehabilitation services, but there have been discussions in Fife. But certainly one thing that has struck us is looking at the needs of the people in Fife, and there's definitely a need for inpatient stabilisation and rehabilitation. That's certainly something that we've noticed and we've had discussions about over the past few months.
Thanks, Angela. I'm going to come to you in a second, Dave, because I think Jason's got a final question, and it's the last one that we're going to get in, if that's okay.
So this is the final question just to the whole panel. And it's just asking, what are the key things that can be done to avoid unplanned discharges? So that's to the whole panel, and that will probably take it right to the wire.
Thanks, Jason. Dave, did you want to come in?
Yeah, quite happy to.
Thank you.
One of the things that we've experienced that's key for us, as I said earlier, is building relationships. But that's not just with the individual, because once you get to know that person and get to know their life story, you start to hear the relationships and the dynamics. So it's involving, where possible, the whole of the family. Well, that is where the whole family is involved, obviously. But for us, what we do is we review every 4 weeks. And what we realise quite quickly, and particularly for retention, is you might deal with a housing issue, but you've not dealt with the benefits because of universal credit and the way it functions. So it's just holding in there and taking it a step at a time with them. We found that blends well.
Thanks, Dave. Angela?
Yeah, I would say it was about being able to have that discussion with the person to find out what their needs are. And we've got care opinion, and we look at care opinion and to ensure that people feel that, they want to stay within the service as well, that they're treated, courteously and kind, within the service. And these are basic things, but they're really, really, really important.
Thank you. Kate?
I think it's about providing that holistic support that encompasses every aspect of an individual's life. That means that their needs are being met. It's about providing realistic care rather than tokenistic care that ticks boxes. And I think it's about focusing on anticipatory care as well. So if you know someone is going to be at more risk, if you know a certain time of the year is triggering, if you know that there's been an incident, for instance, having a child removed or a bereavement that is going to increase risk of unplanned discharge, wrapping the care around to ensure that person feels supported and feels listened to and that they matter.
Thanks, Kate. And Trina, last word to yourself on this one.
I totally agree with what everyone's been saying. I think it is that it's the crux of MAT Standard 5 and providing quality care, and whether that is being able to respond and step up input at times where it's required, but also that point of not over treating people and not asking people to come in for arbitrary appointment requirements, etc. So again, where it's just the whole caring and person-centered service delivery.
Thanks, Trina. I said final word, but Jason, is there anything you want to add about what you think are the key things that we can do to avoid unplanned discharges?
Yeah, definitely. So some people mentioned that the assertive outreach, people in the engagement group really appreciate somebody coming, knocking at their door. What they've also called, and I think it might have been yourself, Dave, is people said, there's no point sending me a letter because I'm not going to be opening it, because there's just that fear of opening letters and dealing with that. But definitely, I think in order to stop the unplanned discharges, it's just sort of being flexible enough to work with people there and then and deal with the housing issues in the Department of Work and Pensions and all that sort of stuff. Because if you can deal with all that, that prevents it getting to the critical stage that people feel enough is enough. And then that ends up resulting in them being discharged for services.
Thanks, Jason. Okay, so we've come to the end of the webinar. As highlighted, this is the 5th in a series of webinars on the MAT standards implementation, and the session on MAT 6 will run at the same time on the 18th of November, so small gap in between, so back on the 18th. If you haven't yet booked for this session and you'd like to do so, a link will be on the evaluation email, or you can register on the website. And finally, I would really like to thank you all for attending, for submitting your questions and contributing to the discussion, and a special thanks to today's presenters who've all been excellent. So thank you all very much again, and goodbye for now.